Okay, so thank you everybody for coming today. This is our first 2021 Cannabis Grand Rounds, and it is such a pleasure to introduce Donald Abrams to give the talk today. He is an oncologist at the Zuckerberg San Francisco General and a professor emeritus of medicine at the University of California, San Francisco. He has an integrative oncology consultation practice at the UCSF Osher Cancer for Integrative Medicine and started his training doing molecular biology as an undergraduate student at Brown University and then graduated from Stanford School of Medicine. He went on to complete an internal medicine residency at the Kaiser Foundation Hospital in Francisco and became a fellow in hematology oncology at the Cancer Research Institute of University of California, San Francisco. He was one of the first original clinician investigators to recognize and define many early AIDS-related conditions and has long been interested in clinical trials of complementary and alternative medicine interventions for HIV/AIDS and cancer, including evaluations of medicinal cannabis. His articles have been published in New England Journal of Medicine, Lancet, Annals of Internal Medicine, and JAMA. Dr. Abrams was one of the original clinician investigators who recognized and defined many early AIDS-related conditions, and he has received funding both from NIDA and the University of California Center for Medicinal Cannabis Research, the CMCR, to conduct clinical trials of the safety and efficacy of cannabinoids in HIV infection, as well as trials to look at the safety and efficacy of cannabis in cancer patients, which we'll hear about today. He's co-authored a chapter on cannabinoids and cancer that he co-edited with Dr. Andrew Weil, and he was the member of the National Academies of Sciences, Engineering, and Medicine Committee that published the health effects of cannabis and cannabinoids back in 2017. And on a personal note, Dr. Abrams has been a dear friend and a very instrumental mentor for myself as well as for other colleagues in our field. He has published the foundational studies looking at cannabis for pain and pain populations that are cited hundreds of times. And it is really a distinct honor to hear from Dr. Abrams today. So thank you so much for coming. And please, for those of you who do have questions along the way, we will have time to respond to them. And if you can insert your questions in the Q&A box, that would be great. So thank you so much. Dr. Abrams, please take it away.
Thank you very much, Ziva. It's a pleasure to be here. Let me just get my screen going here. So, of course, my disclosures, I am a scientific advisor to a number of different companies. And I did go to college in the 60s, which usually draws some laughter, but in truth, I think is one of my most important disclosures. I will be discussing off-label use of a federally illegal substance. So talking about cannabis and cancer, the Siberian ice princess is the body of a woman that was very well preserved in the ice. Under MRI, she appears to be in her mid-20s and has metastatic breast cancer with bone metastases. Around her waist is a rope, at the end of which is a pouch, in which are the flowers of the female plant of Cannabis sativa, suggesting to the anthropologists or archaeologists, whoever makes these hypotheses, that the Siberian ice princess may have been using cannabis to ease symptoms of her cancer or perhaps even to treat the cancer itself. A bit of a large jump because we don't know that everybody in this tribe wasn't buried with cannabis around their waist. That being said, when we look at symptoms that cancer patients experience, weight loss, cachexia, early satiety, anorexia, pain, anxiety, depression, nausea, and vomiting, we can appreciate that there is one intervention, i.e. cannabis, that can address all of these complaints. Rather than prescribing 5 or 6 different medications that might all interact with each other, or with my chemotherapeutic intervention, I generally can recommend cannabis to my patients. And as Dr. Cooper said, we were both on the committee that wrote the health effects of cannabis and cannabinoids, published in January of 2017. And in the single chapter on therapeutics, we concluded with the strongest evidence that in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. Also relevant to patients with cancer, in adults with chronic pain, patients treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in their symptoms. So why did anybody even think to study dronabinol or delta-9 THC for the treatment of chemotherapy-induced nausea and vomiting? Well, in the 70s, the decade with Jimmy Carter, president before the Reagans and their aggressive Just Say No campaign, many young people with young people cancers, i.e. Hodgkin's lymphoma and testicular cancer, were treated with the same highly emetogenic chemotherapeutic regimens that we use today. And back in those days, the only antiemetic we really had available was prochlorperazine. And patients would tell us that, you know what, cannabis is more effective than your prescribed antiemetic. So this led a small pharmaceutical company and investigators at the National Cancer Institute to look at dronabinol or delta-9 THC as an antiemetic. And in fact, in the clinical trials, which I'll show on the next slide, oral THC was better than placebo and equivalent or superior to the currently available antiemetics. Smoked THC appeared superior to oral. However, since the 70s and 80s, we've increased our armamentarium of antiemetics, and cannabis would not rank as the most potent. But again, dronabinol was approved in 1986 for chemotherapy-induced nausea and vomiting, as was nabilone, a synthetic THC. The indication, as I mentioned here, was expanded in 1992 to include treatment of anorexia associated with weight loss in people with AIDS. Interestingly, as you can see from the wording of this advertisement, it did not impact on the weight. It only increased appetite in these patients with the advanced AIDS syndrome of AIDS wasting. However, up until 1992, the federal government, in its wisdom, was giving a handful of patients with so-called orphan diseases 300 cannabis cigarettes a month because it was felt that it was useful for their disease. And the government became concerned that AIDS wasting patients, numbering in the thousands to tens of thousands, would suddenly knock on their door requesting 300 cannabis cigarettes, which they never would have been able to provide. So in 1992, Bush 1 closed the compassionate use program, and the FDA expanded the indication for dronabinol to include treatment of anorexia associated with weight loss in AIDS. So the studies looking at dronabinol as an antiemetic and nabilone were conducted mainly, as I mentioned, in the 70s and 80s. And there have been numerous meta-analyses of these same trials. Interestingly, the earlier meta-analyses all claimed that dronabinol was effective. A Cochrane review conducted in 2015 included 23 of the randomized controlled studies and concluded that cannabis-based medications may be useful in treating refractory chemotherapy-induced nausea and vomiting. Interestingly, to my read, 3 recent systematic reviews and overviews of systematic reviews published since 2015 have been less enthusiastic about the effectiveness of dronabinol in chemotherapy-induced nausea and vomiting. One of the concerns that my oncology colleagues have is that, gee, we don't use prochlorperazine anymore. So this study, done still a number of years ago, looked at comparing dronabinol for delayed chemotherapy-induced nausea and vomiting to some of the more effective agents that we're currently using. Dexamethasone, a steroid, and ondansetron, widely used, the most widely prescribed antiemetic probably. And in this study, the total response was the same for the ondansetron or the dronabinol, and both were superior to placebo. And patients actually mentioned that they had less symptoms using dronabinol compared to the ondansetron. So again, shows that delta-9 THC is probably as effective as what we currently have available. But where are the clinical trials of cannabis in chemotherapy-induced nausea and vomiting? Well, I'm sure, as most of you are aware, it's very difficult to get funding to conduct a study looking at the potential therapeutic benefit of a Schedule I substance. The only legal source of cannabis for research is NIDA, the National Institute on Drug Abuse. And NIDA actually has a congressional mandate to only study substances of abuse as substances of abuse. So if you want to do a clinical trial looking at the potential therapeutic benefit of cannabis, you must use NIDA cannabis, but they cannot fund such a study. So there are only 3 controlled trials of inhaled cannabis in patients with chemotherapy-induced nausea and vomiting. In one, the botanical only became available after dronabinol, its most potent constituent, had failed, so obviously doomed to failure. The third was a randomized double-blind crossover trial in 20 cancer patients looking at dronabinol versus smoked cannabis. And the results of this study I find difficult really to interpret. Nabixomoles is a whole plant extract of cannabis with a 1-to-1 ratio of THC to CBD cannabidiol. And there have been numerous studies of this agent in cancer patients, but to date, this drug is not available in the United States. It is licensed and approved in Canada, the United Kingdom, and the European Union, as well as Australia and New Zealand, on the basis of studies showing improved spasticity in patients with multiple sclerosis. A small study in patients with chemotherapy-induced nausea and vomiting, 16 patients using Nabixomoles or placebo demonstrated that the Nabixomol spray under the tongue was more effective than placebo when added to standard antiemetics. An interesting, more recent study that didn't involve cancer patients surveyed 153 people presenting to a gastroenterology clinic for evaluation, and they were asked to rate 29 antiemetics on the basis of their potency. The mean efficacy score of all the anti-nausea treatments was 1.73. After adjusting, cannabis actually was rated by these patients higher than ondansetron or promethazine. So interestingly, the patients ranked cannabis number 1. And I see this all the time as well. In the days when we had to write recommendations for our patients in California to access cannabis, this was a request I got from a 48-year-old gentleman with metastatic colon cancer asking to renew his cannabis recommendation. Although I did not use it until my last 5 sessions of chemo, me getting over the stigma of its use, it did what no other drug could do: completely solve the severe nausea I had. It allowed me to play with my children, attend their sports and school functions, and just function very normally in day-to-day activities. I cannot thank you enough for giving me that option. I'm currently on a chemo vacation after a clean scan, and the only time I use medical marijuana now is when I have trouble sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceutical options. So of course, I gladly renewed his letter. Interestingly and unfortunately, the American Society of Clinical Oncology, the parent organization of us oncologists, issued a few years ago a statement from an expert panel that recommended FDA-approved cannabinoids, dronabinol or nabilone, only be used to treat nausea and vomiting that is resistant to standard antiemetic therapies, even though it was shown to be as efficacious, and the evidence remains insufficient to recommend marijuana in this setting. Well, I'll tell you, as an oncologist in San Francisco for 38 years, I see many patients, even up until today, who forego standard antiemetic therapies and prefer to use cannabis effectively to treat their chemotherapy-induced nausea and vomiting. It doesn't work for everybody, but ondansetron causes significant constipation. And I find that if you're a patient living with or beyond cancer, the ability to have normal bowel movements is something that people really appreciate. And so people use cannabis and don't suffer from that side effect of ondansetron. What about appetite? cannabis may be the only antiemetic that is also an appetite increaser. We know that anandamide, the endocannabinoid, in low concentrations in mice leads to a potent enhancement of their appetite. It's felt that the cannabinoid 1 receptors in the brain are implicated in food intake control by way of their location in the lateral hypothalamus and the limbic system. If you take mice and genetically program them not to have a CB1 receptor, they eat less than their wild type litter mates. So it's felt that the CB1 receptors are involved in the motivational and reward aspects of eating. What do we know about the effects of cannabis on food intake? Well, Fulton, who generated the so-called Fulton puff procedure that we use in many of our clinical trials to standardize a dosing of an inhaled treatment, did a small study way back many years ago, where he put 2 groups of 3 adult men in a residential facility for 15 days. The participants stayed in their room working for the first part of the day and were allowed to socialize for the second part of the day. They received 2 cigarettes containing what we would consider pretty low dose THC or placebo that were smoked during both the private and the social parts of their day. Smoked cannabis increased caloric intake 40% over placebo. And that increase was noted during both periods, the private and the social. And it was constituted by an increase in snack calories, not meals. And the snacks were mainly sweet solid items, not sweet liquids or savory solids. Any of us that went to college would recognize this as the munchies. However, delta-9 THC alone as dronabinol has been studied in perhaps the largest clinical trial of this agent in a randomized double-blind trial of almost 500 cancer patients with advanced weight loss. And dronabinol was compared to megestrol, which is a progestational hormone that increases weight mainly through retention of water weight. And you can see that dronabinol appeared to be inferior to the megestrol. And when the 2 were combined, the dronabinol may have decreased some of the megestrol effect. So the conclusion of the National Academies group was that there was not huge support for cannabis or cannabinoids being able to increase appetite. And that surprised many of the people on the committee, but it's again because the studies were looking at just delta-9 THC isolated, which is a very different medicine than what you get when you utilize the whole plant, where the entourage effect produces a very different outcome than just delta-9 THC alone. Another smaller randomized controlled trial of dronabinol in cancer patients did demonstrate that the food looked better, smelled better, tasted better, their appetite improved and their calories increased, but their weight did not gain. 2 more recent studies have again looked at cannabinoids in the significant problem of cancer cachexia. In one study, in 47 outpatients diagnosed with non-small cell lung cancer, one that's very prone to wasting, nabilone versus placebo was investigated. And at 8 weeks, the patients who were randomized to receive nabilone did increase their caloric intake and had higher intake of carbohydrates compared to the placebo group. They noted significant improvement in quality of life, social functioning, pain, and insomnia, but no increased weight. Again, this is studying just the isolated delta-9 THC. An Israeli study looked at capsules containing oil-based THC and a much lower dose of cannabidiol. And these patients were supposed to stay on trial for 6 months. Only 17 patients began the study, 11 remained for longer than 2 weeks, and 6 completed the 6 months. 3 of those 6 gained greater than 10 pounds from baseline, which was the endpoint. 3 had stable weights. Patients did report improved appetite, again, mood and quality of life with less pain and fatigue, but whether or not further research is warranted when people were so unable to tolerate it is unclear. So one question that people ask me all the time is, what is the right ratio of THC to CBD I should take for my nausea, for my appetite, for my pain? And the answer to that is we really don't know, because the only ratio that's been studied and reported in the literature is the 1-to-1 ratio, which is Nabixomoles, the under-the-tongue spray. However, in the Netherlands, pharmacies have 3 different strains of cannabis available for patients to access. One has, 2 of them have very high THC and much lower CBD, and the third one has a little bit more CBD than THC. And people were asked about their symptoms using these different products, and they reported that although they felt less anxious using the higher CBD product, they also had less appetite stimulation. And this seems to be borne out by a study that was reported in a Nature.com publication, looking at 3,341 people who completed self-administered cannabis sessions using the Relief app. And these participants were asked about how cannabis worked across 27 different measured symptoms. And they reported an average symptom improvement of 3.5 on a 0 to 10 scale. Dried flower was most commonly used product in those reporting and was associated with greater symptom relief. Only higher THC levels were associated with greater symptom relief and prevalence of positive and negative side effects. In fact, CBD potency levels were generally not associated with significant symptom change or side effects. And I want to stress this because CBD has achieved this status of a panacea that works and cures everything. And the data supporting it, even from this observational uncontrolled trial, really is quite weak, other than in small children with refractory epilepsy. Let me turn now to pain. We know that elevated levels of the cannabinoid 1 receptor, like the opioid receptor, are densely concentrated in areas of the brain that modulate processing of noxious stimuli. And in addition to their central activity, CB1 and CB2 agonists that combine with those receptors also have peripheral analgesic actions. And cannabinoids and other components of the plant, in fact, the terpenoids and flavonoids, may also exert anti-inflammatory effects. And we all appreciate that anti-inflammatory substances are often analgesic. The analgesic effects of cannabinoids are not blocked by opioid antagonists, suggesting that they do work by way of different mechanisms. The largest body of evidence supporting the use of cannabinoids in pain is actually in patients with neuropathic pain. Most of the studies have been published in patients with HIV-related neuropathy, but a small study in diabetic neuropathy of vaporized cannabis also seemed to have a positive outcome. Well, what about chemotherapy-induced peripheral neuropathy? This is a major problem. Nowadays, we can cure many patients of their cancer, and they are disabled by crippling peripheral neuropathy. In animal models of chemotherapy-induced peripheral neuropathy caused by the 3 major classes of drugs that lead to this outcome, the vinca alkaloids, the platinums, and the taxanes, cannabis and cannabinoids not only can treat the chemotherapy-induced peripheral neuropathy models, but they can also prevent the neuropathy from occurring. So this is very exciting and a reason that I might recommend use of cannabis to patients who will undergo treatment with a neuropathy-causing chemotherapeutic agent. However, the literature to date only contains another one of those small 16-person clinical trials of Nabixomoles, the whole plant extract under the tongue spray with a 1-to-1 ratio of THC to CBD. In this placebo-controlled crossover study of 16 patients, the top line shows you that there was really no difference in pain in the patients receiving Nabixomoles versus those who received placebo. However, they did do a so-called responder analysis and found 5 patients who reported greater than a 2-point drop in their pain on a 0 to 10 numeric rating scale. The average decrease here was 2.6, meaning that the number needed to treat for one to get benefit would be 5, suggesting certainly that further clinical trials of this agent or another cannabis-based medicine are warranted. And looking at clinicaltrials.gov, there are 2 studies that are currently open. One looking at different strength capsules of THC and CBD, and the other a randomized controlled trial of hemp-based CBD in a number of patients that is quite large, considering that there is no pilot data suggesting that cannabidiol would work in this situation. The look at Nabixomoles in non-neuropathic pain in cancer patients has been less than positive. 6 randomized controlled studies were identified for this systematic review, and 5 were appropriate for meta-analysis. All the studies involved Nabixomoles. They had a low risk of bias and included almost 1,500 participants. The meta-analysis found no difference between Nabixomoles and placebo for the difference in the change in average pain scores. And below, you see that this finding remained when only the 3 phase 3 clinical trials were included. And in fact, cannabinoids, not surprisingly, had a higher risk of adverse events compared with placebo. So you can see that in non-neuropathic pain in cancer patients, Nabixomoles did not fare well. And one of these studies, or some of these studies, were done in US patients, which is the reason that this substance has not yet been approved in this country, because there was no benefit observed. Now, we've always been interested in the potential interaction between cannabinoids and opioids, and whether there was a synergistic effect, as has been seen in rodent studies. So we were funded by NIDA to do a pharmacokinetic interaction study to determine the safety of adding vaporized cannabis to sustained release morphine or sustained release oxycodone. So we do all of our patients in our clinical research center at Zuckerberg San Francisco General Hospital. All of our studies are done in the inpatient setting. We brought patients in who are on a twice-a-day dose of sustained release morphine or sustained release oxycodone. We drew their plasma concentration of the opiate on day 1, and the patients vaporized NIDA 3.5%, THC 0% CBD cannabis for 5 days, after which we drew their PK curve again. And you can see on the left, for the 11 morphine patients, day 1 curve showed slightly higher plasma concentrations than day 5 after exposure to vaporized cannabis, but the error bars crossed, so the difference is not significant. In the 10 patients on oxycodone, the curves were entwined. So if the opioid levels stayed the same or decreased, you would expect pain to stay the same or increase. And even though it was not our primary endpoint, as long as we were bringing patients into our clinical research center and doing the study, we did ask them what happened to their pain. So overall, the group came in with an average pain score of 40, and that dropped to 29 on day 5, which was a statistically significant 27% reduction in pain. The pain was reduced greater in the morphine recipients than in the oxycodone recipients. But again, this study was not powered for pain as an endpoint. So all we can say is that there was a trend towards improved pain outcomes. And this is supported somewhat by an Israeli observational analysis. 2,000 Israeli patients who got cannabis licenses and who had cancer diagnoses were evaluated at baseline and at 6 months. And at baseline, 53% of these cancer patients reported having pain in the 8 to 10 range. And at 6 months, it was only 5%. And you can see the other symptoms that have improved. Now, some people have suggested, well, in that 6-month period, these patients may have had their cancer treated successfully and cured. So maybe it's not the cannabis that's leading to the reduction in pain as well as these other symptoms. Regardless, looking below, 1,000 patients reported on changes in their medications. A third reported decreasing concomitant prescription meds, And of those who were on opiates at the onset, a third stopped them and 10% decreased their dose. So that, I think, is a significant finding. Let me turn now to cannabis as a treatment for cancer itself, as was suggested. The Siberian ice princess may have been using it. So this group from Stanford suggested that online search volume for cannabis and cancer increased 10 times the rate for standard therapies and cancer. And the top false news story about cannabis curing cancer generated 4.26 million engagements on social media, whereas the accurate story debunking it generated much fewer hits. Where do we get the idea that cannabis has anti-cancer activity to begin with? Well, in 1975, investigators from Virginia Commonwealth University reported in the Journal of the National Cancer Institute that delta 9 THC, delta 8 THC, and cannabinol inhibited Lewis lung adenocarcinoma cell growth in vitro and in mice. Of note, cannabidiol did not. Since that time, there's been an increasing body of preclinical evidence suggesting that cannabinoids may have anti-cancer activity. Most of this work has come from Europe, particularly Spain and Italy. And cannabinoids have antioxidant, anti-inflammatory effects, which are things that I recommend for my patients in my integrative oncology practice. So there's the possibility of direct anti-tumor activity by way of cannabinoid receptors, that when the cannabinoids complex with cannabinoid receptors on the tumor cells, they induce programmed cell death. And there's also evidence that cannabinoids impair tumor vascularization. Multiple tumor cell lines are inhibited in vitro. And when you take human tumors and transplant them into nude mice that don't have an immune system, cannabinoids can control the growth or can curb the growth of lung, breast, colorectal, and pancreatic carcinomas, skin cancer, melanoma, lymphoma, thyroid cancer, and gliomas. Most of the evidence comes from the laboratory of Guillermo Velasco and Manuel Guzman, my friends and colleagues at the Complutense University in Madrid. Their laboratory studies the effect of cannabinoids on metabolism. And the most metabolically active cells in the body are the brain. So they would take rat brain and grow it up in culture and add cannabinoids. And they said, maybe we can do our work faster if we look at a brain tumor. So they grew up a rat brain tumor cell line and added cannabinoids and everything died. They said, oh, we must have done something wrong. So they did it again and everything died. So they went back to normal brain and added that same batch, wondering if it was a bad batch of cannabinoids, and everything lived. So since that time, they have done very elegant research demonstrating that the cannabinoids, when they complex with the cannabinoid 1 or the cannabinoid 2 receptor, do lead to increased programmed cell death or apoptosis. They've also demonstrated in their tissue culture systems that cannabinoids decrease vascular endothelial growth factor activity. So new blood vessels to supply the tumor are inhibited. And cannabinoids in their hands also inhibit the enzyme matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. So this is all very elegant. However, we in the national academies reported that there was no or insufficient evidence that cannabinoids have any effect on cancers, including gliomas. And that's because, number one, we were asked to look at human studies and particularly meta-analyses and systematic reviews of human studies for the purposes of the National Academy's report. And when human studies weren't available, when meta-analyses weren't available, we were asked to look for high quality human studies. Well, none existed in the medical literature when we reviewed this data up until June of 2016. The best paper we found was an analysis of 34 in vitro and or in vivo experimental studies, again, looking at gliomas. And in that analysis, all but one study did show that cannabinoid selectively killed the tumor cells via direct anti-tumor activity and the anti-angiogenic and anti-migratory effects that I've just mentioned. There was one pilot study. I'm not there yet. Okay. So when I asked patient proponents of why people think cannabis cures cancer, I'm sent a number of cases to consider. 2 children with partially resected pilocystic astrocytomas were stable or had slight progression in the first 3 years after their tumor was resected, but then achieved a complete response over the next 3 years, only inhaling cannabis. Well, this, I believe, is the strongest possible indication, although their tumors were removed, and the pilocystic astrocytomas are known to spontaneously resolve. So was this a coincidence, or did inhaling cannabis have a benefit? A 14-year-old girl with refractory acute lymphoblastic leukemia was sent to hospice, where she began to use hemp oil, and her white blood cell count dropped significantly to the point where she ultimately developed neutropenic colitis and died of a perforated colon. But because her white blood cell count dropped with only hemp oil as an intervention, people suggested that she may have cured her cancer. Well, death is not a good outcome for cured cancer. A 44-year-old man who had a recurrent squamous cell carcinoma of his right cheek and a wound that went from inside to outside applied topical oil that was CBD dominant in sunflower oil. He achieved rapid relief of pain and a 5% decrease in the size of his wound before he died. So I'm not calling that a cancer cure either. 2 38-year-old men, one with a glioblastoma, the most aggressive brain tumor, and one with a grade 3 oligodendroglioma, were both treated with chemoradiation, which is a standard therapy for those brain tumors. And they also received CBD, and they had good clinical responses. Well, I think their chemoradiation and probably their surgery they had before that is what led to their cancers being cured. The final case that I'm sent is an 81-year-old gentleman who had a lung cancer, decided he didn't want chemo, and treated himself with CBD oil at a dose of 6 milligrams twice a day. Notice these doses of CBD and how different they are. Reportedly, his tumor shrunk and his lymph nodes decreased in size, but that is not a cure for cancer. And then there are 2 published case series, one of 119 patients at a clinic in London, treated over a 4-year period, who received pharmaceutical grade synthetic CBD oil at a dose of 10 milligrams twice a day, 3 days on and 3 days off. Clinical responses were seen in 92% of the patients with solid tumors. However, most of the patients also received standard therapies. Only 28 received CBD alone, and no data in this very short publication is presented on those patients. The investigators, however, concluded that CBD is a candidate for treating breast and glioma patients. In a study from Vienna, looking at now 400 milligram capsules of CBD in 9 consecutive brain tumor patients treated there, the authors state that the median GBM survival is 14 to 16 months. Glioblastoma is the most aggressive brain tumor. 3 patients out of the 9, however, had lower grade brain tumors, and they often survive for years. So the median, half survived longer, half survived shorter. In this is normally 14 to 16 months, and they give us the mean, which is the average of all survival, being 22.3 months, which they state is longer than would have been expected. Yes, for GBM, but they're including 3 lower grade tumors that have much longer survival. So I'm not impressed with that one either. The first interventional study was done by Manuel Guzman, a PhD who went to the Canary Islands and found 9 patients with recurrent glioblastoma and treated them with small doses of THC dripped via a catheter into their tumor daily for 15 days while they were getting chemotherapy. He claims that the treatment was well tolerated. I told him, Manuel, we don't treat brain tumors topically, and I don't know how well tolerated having a catheter in the brain would be. He saw no effect on survival different from chemotherapy alone. However, when he took slices of those brain tumors in vitro, THC inhibited the proliferation and decreased the viability of the cancer cells. And it was later demonstrated that CBD enhanced the inhibitory effects of THC on these glioblastoma cells. We now have just published last month the results of a trial of Nabixomoles, the 1-to-1 ratio of THC to CBD whole plant extract under the tongue spray, compared with placebo in patients receiving dose-dense temozolomide for, again, recurrent glioblastoma, the most aggressive brain tumor. There were 12 patients on Nabixomoles and 9 receiving placebo. And the interesting result here was that 2/3 of both groups progressed. Their tumor progressed in the first 6 months of the study. However, despite that, the group using Nabixomol somehow had a much improved 83% one-year survival compared to 44% in the group using the placebo. Interestingly, the study was a feasibility study and was not powered for survival as a primary endpoint. At 2 years, the overall survival again still favored the group receiving Nabixomoles. So this is an interesting finding and the first study demonstrating that any cannabis-based medicine may in fact prolong survival, particularly in patients with brain tumors. One thing that I find disturbing for future studies of cannabinoids in patients with malignant disease is that looking at different tumor types, the over or under expression of CB1 and CB2 is across the board and associated with poor prognosis in some situations and good prognosis in others. For example, CB2 is overexpressed in brain tumors that are high grade and overexpressed in colon cancer associated with poor prognosis. On the other hand, liver cancer, increased CB2 is associated with an improved prognosis. So maybe we should measure CB1 and CB2 on all tumors as we're doing now with personalized cancer therapy, so we can sort of tease out when it may be worth looking at a cannabinoid-based intervention. Unfortunately, another piece of research coming out of Israel is another downer for looking at cannabis-based medicine in cancer. The group of Dudi Meiri evaluated the anti-tumor effects of whole cannabis extracts containing significant amounts of differing phytocannabinoids on different cancer cell lines from various tumor origins. In the end, they reported on 12 extracts and looked at 12 different cancer cell lines. The specific extracts impaired survival and proliferation, and again, induced programmed cell death. Pure delta-9 THC did not reproduce the beneficial effects of the cannabis extracts in killing the cancer cells. Cannabis extracts with similar amounts of delta-9 THC produced significantly different effects on the survival of specific cancer cells. And cancer cells from the same origin, i.e., 2 different lines of cancer from prostate cancers, responded differently to the same extracts. So again, this makes extrapolation from these in vitro studies to human studies difficult to comprehend. Now, again, there are those patients out there, however, claiming that cannabis alone cured their cancer. My friend and colleague Dylan Zilla in Minneapolis is doing an observational study of cannabis as an anti-tumor agent. He's inviting any patient who believes that they cured their cancer with cannabis alone to participate in this national survey analyzing the impact of cannabis use on tumor control, especially in patients with metastatic cancer. And he, in doing this study, is asking to be able to review the patient's chart, to ascertain that cannabis was in fact their only anti-cancer intervention. So summing up, one of the reasons that I would recommend cannabis to my patients is demonstrated in this graph here. I have a lot of patients, survivors of estrogen receptor positive breast cancer, and they are now back to work. And when they finish a day at work, their colleagues would like to go out for a drink, or they come home from work and their husband comes home from work and he'd like to have a cocktail. Well, this shows you that the relative risk for developing estrogen receptor positive breast cancer is linear related to the number of alcoholic beverages a patient consumes. So my breast cancer survivors came to me and said, I would prefer to be socially lubricated without the risk of alcohol. And I would definitely write them a recommendation when they were needed. But isn't smoking still a major cause of cancer? Is it safe for our patients to inhale their cannabis? Yes, tobacco still accounts for about 29% of avoidable malignancies. However, we concluded that there is moderate evidence of no statistical association between cannabis smoking and the incidence of lung cancer. Some of that came from the elegant and largest study in the LA basin done by my friend and colleague Don Tashkin at UCLA, which demonstrated no increased risk of lung cancer in 1,450 patients using various degrees of cannabis recreationally. We also found no moderate evidence of no statistical association between cannabis use and the incidence of head and neck cancer, something that is increased in tobacco users. We found limited evidence of a statistical association between cannabis use and testicular cancer. Now, during our evaluation, we had an outside person come to talk to the committee from the National Driving Safety and Transportation group to talk about whether or not there are increased automobile accidents in states where recreational cannabis has been made legal. And he said there is a slight increase, but if you adjust for one factor, that increase disappears. He says, who smokes cannabis? Young men. Who gets into automobile accidents? Young men. If you adjust for that, the association disappears. Similarly, who smokes cannabis? Young men. Who gets testicular cancer? Young men. So this statistical association seen is that and not causative. It's very similar to the finding that there are increased drowning deaths in months where ice cream is overconsumed. True, and unrelated. So as an oncologist, I share many of my colleagues' concerns about inhalation or oral ingestion of cannabis. One that I think is not founded or nothing to worry about is the development of pulmonary aspergillosis, a severe fungal infection that many oncologists are concerned about when patients inhale cannabis. Aspergillosis is mainly related to severe and prolonged neutropenia. And in a study of 19 patients with HIV who had aspergillus in their bronchoalveolar lavage, again, it was associated with more severe neutropenia, severe immunosuppression, the use of steroids, and prior pneumocystis pneumonia, and cannabis use was not associated. One area where I do share concerns is the potential for drug botanical interactions. We do know that both CBD particularly and THC impact many isoforms of the cytochrome P450 enzyme system. And I have seen patients using highly concentrated CBD oils who appear to me to have gotten into some trouble by increased concentration of pharmaceuticals they've been prescribed because CBD is an inhibitor of isoforms of cytochrome P450. The Israelis have reported the effect of cannabis use on immunotherapy. In the first study reported, 89 patients on the checkpoint inhibitor nivolumab alone were compared to 51 patients using cannabis while on nivolumab. The study demonstrated a decreased response rate in the patients who were using cannabis but reported at that time no significant effect on progression-free or overall survival. However, a more recent report published just last year did demonstrate a significant decrease in both overall survival and median survival, time to tumor progression, and overall survival. Excuse me, sorry about that. In patients who used cannabis and while receiving their immunotherapy. Now, the problem with this study, as I see it, again, it was not a randomized placebo-controlled study, but an observational study. And when you do an observational study, you are at risk for bias. And the bias that I see here, if you look at the arrow, immunotherapy was used as first-line treatment in significantly more patients who didn't use cannabis than those who did. And I think we know that every subsequent line of treatment in a cancer patient is going to be less effective. Users of cannabis had less immune-related adverse experiences, and that's felt to be because the cannabis was decreasing the immune response. So they suggest at the end that cannabis consumption should be carefully considered in patients with advanced malignancies treated with immunotherapy. And again, although this is not a randomized placebo-controlled trial, and I do appreciate the bias in this first line versus second or third line therapy, I do caution my patients on immunotherapies about these findings so that they can make an intelligent decision. Finally, I just want to say that an old survey of physicians done by WebMD demonstrated that 2/3 of us believe that it is useful, and amongst the subspecialties, oncologists showed the strongest level of support. And this is also seen in pediatric oncologists. Ilana Braun at the Dana-Farber did a study of 400 random oncologists surveyed and found again that 80% reported conducting discussions regarding the benefits of medical cannabis. 78% said the discussions were patient initiated. 2/3 viewed cannabis as a helpful adjunct to standard pain management, and 2/3 thought it was equally or more effective than standard therapy for anorexia and cachexia. Less than 50% report recommending it clinically. However, only 30% felt sufficiently informed to make the recommendation. So if my dogs will allow me to conclude, despite a dearth of published evidence related to barriers to research, I believe botanical cannabis is a useful adjunct to standard treatment in alleviating side effects of cancer, perhaps superior to more widely isolated cannabinoids that are more studied. Although preclinical findings are promising, there is no convincing evidence in the medical literature to date supporting anti-tumor activity of cannabis or cannabinoids. CB1 and CB2 assessment of all tumor specimens should be considered. More research should be done exploring the direct impact of cannabis-based interventions on malignant tumors. Oncologists' concerns about the use of cannabis during treatment can be largely allayed, and additional research and education is always warranted. And with that, I'll stop and thank you for your attention and your patience with my dachshunds who are going crazy because somebody must have come to the house. Sorry about that. We can't.
No, not at all. Thank you so much, Dr. Abrams. Thank you, Dr. Cooper, for arranging all this. And thank you for the audience for attending. We have several really excellent questions. But first, we're going to give you a digital and virtual UCLA round of applause for doing this. We really always welcome. What an incredible talk. Here's a few questions from the audience. Number one, to what extent do you think prior extensive cannabis use is a predictor for a positive, effective response for neuropathic pain patients?
If I understand that correctly, is it saying that if people are already using cannabis and then get chemotherapy, is that going to have a benefit?
Yeah, particularly for neuropathic pain.
Yeah, there's no answer to that question because nobody's looked at that. I think it would be an interesting thing to evaluate, certainly.
That's terrific. And that comes from, of course, Dr. Tom Strauss. Dr. Noah Fetterman, who is our pediatric oncologist, who's been here now for 15 years plus, he indicates that he has not seen any cases where cannabis has created an anti-cancer response. So he just wanted to put that comment out there, and you graciously answered his question about immunotherapies. We have another question about, from a clinical standpoint, about dose standardization. Is there, in your mind, any sort of dose standardization system for cannabis that can be used just like a morphine equivalent dose for opioid use? Anything like that at all on the horizon or clinically?
Well, my understanding is NIDA is trying to establish that, but I think that's not going to lead to anything personally, because, you know, different people tolerate cannabis in different ways. And, you know, it's the THC that's the most psychoactive and that does complex with the CB1 receptor, but different people probably have single nucleotide polymorphisms of their cannabinoid 1 receptor, which means that if you use cannabis, you're going to get paranoid, or you're going to get euphoric, or you're going to have no reaction at all. So, you know, I think trying to come up with that, it's an ambitious project, but I don't think it's going to lead to anything.
Yeah, thank you for that. And again, I think the key word I'm hearing from you is that term botanical cannabis. And I think that's such an amazing statement right there, because one question I had is, what does the parent compound of dronabinol come from? It's person made, it's synthetic, right? But where does it originally come from? It's not plant-based, right?
Right. I think that it's synthetic, as you say, and the nabilone is a synthetic sort of cogener of delta-9 THC. It's not it exactly either. So yeah, I'm not a pharmacologist, so I don't know. I think they just make it in a lab, I would guess.
Yeah, it doesn't come from some tree somewhere. And
yeah, no, I mean, Nabixomoles is a whole plant extract. I visited their facility in the United Kingdom, which is a huge football field size grow rooms, now expanded to about 4 or 5, where they're actually growing the plants, and they extract the constituents of the plant, and then they modulate it so it has a 1-to-1 ratio of THC to CBD. So that is really a cannabis-based medication.
Very interesting. And for those on the webinar not familiar, Nabixomoles, of course, is known as Sativex. I don't know if it has any other names out there, but that's the name I'm familiar with. That just puts us up to our 1 o'clock hour. We do have a couple closing announcements, and hopefully we'll have a few more barks from your dogs, who clearly love this talk so much. They're literally barking at you. I mean, I've not had a talk where I've had an audience bark at me. I've had an audience leer at me, but that's another story. Thank you again for doing this. We have a couple of really exciting things coming up. First, April 22nd is the return of our cannabis conversations during the time of COVID. And this month we're bringing in, we're very fortunate to bring in Dr. Ian McGregor of Australia, who's going to be talking about cannabis, his cannabis work, including effect on athletic performance. Then we have our big annual conference is also returning on May 21st in the morning for a few hours, where we're highlighting a lot of the work done by UCLA Cannabis Research Initiative and the many colleagues we now have at the UCLA Health System on our research on cannabis. You'll be hearing from researchers that have received funding from the BCC, the Bureau of Cannabis Control, and a number of exciting projects on research. Lastly, we will have another grand rounds before the end of the academic year. Right now, it is tentatively slated for June 17th, also a Thursday at 12 p.m. And look for announcements. If you have any topic ideas or speakers you want to hear about, please let us know. For those of you who also ask questions in the Q&A, we're going to take those down and we're going to email that out to you. And Dr. Abrams, perhaps he would be so kind to email those back to you and in the near future. So with that, we conclude this quarter's UCLA Cannabis Grand Rounds. Everyone have a terrific day. Thank you, Dr. Cooper. Thank you, Dr. Abrams, one last time. Everyone have an absolutely terrific day. And now the dogs are quiet.
Thank you.
Now the dogs are quiet.
Thank you so much, Dr. Abrams. And we look forward to seeing everybody on April 22nd.